of issues that plague Africa and leaving us with recipes for action. And I'm going to basically try to build on that and provide a different perspective or at least information on another area that impacts on health. Like I told Dr. Adekunle after his presentation, I said he's done quite a lot of work for me, and I don't have to give you numbers, I don't have to give you statistics. He's done all the numbers game. So you are all up on numbers now. I think the question that one always asks is there room for technology, for high tech, particularly when you are dealing with healthcare issues in sub-Saharan Africa? And I would like to submit to you that yes, there's room for technology, particularly with regards to health, and the concept which my colleague who talked earlier had addressed, that in terms of whether it's even in the face of so much malnutrition, in the face of so much suffering, so many infections, what's the place for high-quality technology? I hope I will convince you at the end of my presentation that not only is there room for it, there is actually a dire need for technology in the country. I think it's safe to say that technology impacts every sphere of our activities, and health is no exception. I'm going to focus on health technology as it applies to laboratories. Health technology clearly cuts across boundaries of management of patients, including things like imaging techniques, robotics now in surgery. I'm not going to advocate robotics as the mainstay of management of patients who require surgical intervention in Africa. But selective application of technology clearly has a place to and has a role to play in what lies in our future. And I think there are numerous applications in laboratory diagnostics that illustrate this. I think laboratory diagnostics is a good place to look at how far technology has advanced and how it has revolutionized what we do in patient management, and particularly its impact on clinical care and outcomes. For those of you who are familiar with pathology diagnostics, this is a very familiar ground. The traditional way by which we make diagnosis is that the patient complains, I have a headache, for instance, and this headache doesn't seem to go away. And after the headache started, I began to feel some sensations of weakness in the left half of my body. And in the last few days, I have been having seizures. And it's a seizure that finally caught the attention of the family, and the family said, now you've got to see a doctor because you're having seizures. Well, the doctor says, all right, we need to do some imaging studies. The imaging involves CT scans, MRI. And after the imaging results came back, something is clearly wrong in the brain, and in this particular case, in the brain, and the patient is now referred to a neurosurgeon. And the neurosurgeon says, okay, we've got to operate, we've got to find out what it is, we have to do a biopsy. The biopsy is taken, and the biopsy is sent to the pathologist, who hopefully is a neuropathologist like me, who looks at the tissue and hopefully sees something like this and makes what we refer to as a histology diagnosis. This is the age-long way we make diagnosis. And once diagnosis is made, the decision is taken as to how to treat the patient, which may involve various modalities, radiation, chemotherapy, or a combination thereof. The diagnosis invariably specifies the treatment. And this treatment is not without side effects, and the outcome is unpredictable. These patients are treated under this old traditional diagnostic approach with what appears to be what I would call one shoe fits all. And when the patient is being counseled, the prognosis is usually it may work, it may not work. We've seen people with whom it worked before, we've seen people with whom it did not work, and we don't know which one you are. We cannot predict the outcome. Well, we do better than that now. And this is where application of new technology has transformed in our understanding of many of these tumors. Tumors with the same diagnosis in different patients may have different outcomes based on the differences in the biology of the tumors, even though they have the same diagnosis. And how do we know that? We now interrogate tumors. There is no gainsaying that in this room we can say we are all human beings. And if we are all human beings, we have some common traits. We can roughly classify everybody in this room into two groups, male and female. Within that subgroup, there's a difference between males and females. And within the subgroup of males and females, we can then say we have young and old. And we have the very young and the very old. The very young can withstand some trauma that the very old cannot withstand. These are the individual characteristics that also are common with tumors. Tumors, they may look alike, but they have different, what we call biological signatures. So if you interrogate these tumors with what we call microarrays, some of you have heard of microarrays lately. If you interrogate these tumors, you can interrogate the tumors by doing multiple analysis on their DNA, which is the code for whatever genes they express. Or we can interrogate the messenger RNA, which is actually the expression of the DNA code. Whichever one you do, what we'll find out is that you can actually subclassify tumors, whether it's colon carcinoma, whether it's pancreatic carcinoma, whether it's lung carcinoma, whether it's brain tumors or glioblastoma. You can interrogate them in this fashion, and you can get what is now regarded as a genetic signature or an expression signature for each of these tumors. I don't know whether you can see it. If you look at the top right-hand corner here, you can see some red here. These are each of the lanes here represent different tumors. And on this side here, the tumors here have this red staining, or this red color, which means that they have high levels of expression of whatever these markers are. And the tumors on this side have expression of this other set of markers, which these ones don't have. And depending, if this is when you analyze the tumors without putting any information into the data, just say, what are these tumors making? Or what are the characteristics of these tumors based on the interrogation that you have done with the microarray? We call that unsupervised analysis. If you then put specific questions Then we call it supervised analysis. And this supervised analysis allows you to overlay the pattern of expression with whether they are poor prognostic category of tumors or whether they are good prognostic category of tumors. So here, when you do supervised analysis, you now have tumors that fall into this category that have a high expression of this signature of biological molecules, which are poor prognostic category, versus tumors that don't have this signature here, they don't have it here, but they have another signature, which are good prognostic category. If you then do a plot of survival for these two groups of patients, you see below here, you have a survival plot that shows that the patients who have a particular signature do better, they survive longer, compared with these patients, many of whom are dead within a few short interval. So this signature that is present in this group of tumors allows us to predict that patients who have this signature are going to do poorly. And patients who have this signature are going to do well. Not only does it allow to predict, then you can then ask the question, how should I treat patients who have this bad signature differently from those who have this good signature? And that brings us into the realm of now targeted therapy, where you are looking at the signature of a tumor in an individual patient, and you are now targeting those signatures or targeting the tumor based on the signature that the tumor shows. This is where the rest of the world is, and this is where Africa must go when it comes to management of malignancies or tumors. You may be then asking the question, is this cost effective? Well, if it was you, would it be cost effective? How many people should we allow to die because we can't afford it? How many people should we allow to die because they are Africans? That's the question we want to ask. But before I address that further, let me show you examples of potential treatment options, depending on what the tumors make. This molecule that you're seeing here is a protein that has a portion of it sticking out on the cell membrane, sticking out externally. There's a portion of it within the cell, within the membrane. There's a portion of it within the cell, the cytoplasm itself. And mutations or the misarrangement of the order of nucleotides in this particular protein results in what we refer to as mutations that can be in various segments of the gene that codes for this protein. The bottom line is that this protein is normally well controlled, its expression is well controlled, its activity is under regulation. But when you have alignment or different changes in the sequence that codes for the protein, these proteins they develop a mind of their own. They become auto-regulatory, they fire without control, and they don't respond to normal regulatory mechanisms, and that is what is the basis of cancer. A particular gene that's called KIT is this particular one is called KIT. It belongs to a family of tyrosine kinase receptors that is seen in a particular tumor that we call gastrointestinal stromal tumor. Patients who have this mutation in their tumor, fortunately, will respond to what we call a tyrosine kinase inhibitor. In this case, The tyrosine kinase inhibitor is a drug called Glibenclamide. This is the trade name. The biological name is imatinib. This is an example of a patient who has this gastrointestinal stromal tumor or GIST. This patient, with scanning, shows multiple tumors in virtually most of the abdomen. Everywhere you see black staining or black color shows the presence of tumor. Within 24 hours of the diagnosis of KIT mutation in this particular patient and start of Glibenclamide, 24 hours, at least a quarter of most of these tumors have already disappeared, cells have disappeared. 7 days later, 2 months later, 5.5 months later, all the tumor is virtually gone. This is what is showing here is the bladder and the urine that shows the radioactive tracer that was put into this patient. The cost of this Glibenclamide is incredible. It runs into thousands of dollars. I will ask the question again. If it were you, how much would it cost? Would you pay the cost? Another example of tyrosine kinase inhibitor use is in lung carcinoma. This is an MRI showing the lung, and all these, everywhere that is white here, indicates the presence of tumor in this patient. This tumor was analyzed and was shown to have amplification of the epithelial growth factor receptor, and the patient was put on the EGFR inhibitor, another tyrosine kinase inhibitor. 4 months after the patient was diagnosed and treated, most of these tumor that's all over has gone down dramatically with clear-cut improvement in patients' welfare. You can then say, that's an American patient, or it's a patient from UK. They have those tumors, Africans don't have those tumors. Well, in the 50s and 60s, we were told that Africans don't have peptic ulcer. How many of you in this room have peptic ulcer? Ulcer disease. If you look at this leading cause of deaths in Africa, Sub-Saharan Africa, compared with North America, with Northern Africa, and compared with the rest of the world, I want to call your attention to malignant tumors here. Even though we have infections, the commonest problems, malaria, and all of those, it is number 7 on the list. Malignant neoplasm is number 7 on the list for Africa, with 4.5% of the deaths in the continent related to malignant neoplasms or cancers of various types. If you compare the numbers with North America, the mortality rates in Africa and incidence are shown here. With incidence, you can see that the incidence of malignancies of cancer is much higher in North America. In this case, about 34 per thousand in North America versus 108.1 per thousand in Africa. However, look at the mortality, death from malignant neoplasm, from cancer. Compared with the United States has much higher survival from its high incidence with mortality of only 1 to 2.4. Whereas Africa, of its 108.1, 90.6 are dead. So So why are the Americans surviving and the Africans are not surviving? Treatment, diagnosis, opportunity. So when people give you incidence data, you say Africa doesn't have a lot of it. But the few who have it, you don't unanimously die. And we have always talked about incidence of infections or communicable diseases being the highest. Prediction is that by the year 2020, we should be getting almost an equal number of communicable and non-communicable disease, and in the next 50 years, non-communicable disease will become the commonest cause of mortality in Africa. So the next wave of cancer in the world is going to come from Africa. A number of reasons for that, and I will show you in a minute that the cancers you see in Africa are a little bit different from the cancers that we see that is seen in the rest of the world. The cancers that are seen in Africa are often cancers that are related to infections. Some of them are preventable. Some of them require different approaches to management than the ones that are seen in North America or in Europe. CA cervix, for instance, carcinoma of the cervix, related to HPV infections. Now we have immunization for HPV that can prevent that. You have Kaposi sarcoma in HIV infected patients. Now we have, but beyond those examples that are related to infection, you have liver cancer again, which is related to B virus infection. But beyond those, there are new emerging malignancies that have nothing to do with infections. There's a high incidence of carcinoma of the prostate in Africa, in the African population now. There is a very high presence of carcinoma of prostate among elites, university professors, academicians, businessmen who are in their 60s or in their early 70s. That's when they develop them. And actually, not only that, we also have a relatively lower age incidence of where prostate carcinoma occurs in Africans. It's now suggested that instead of starting monitoring of PSA at 50, which is the recommended age for everybody, African Americans and Africans and Black or African descent are encouraged now to check their PSA at the age of 40. Because we are seeing so many who are developing carcinoma at the age of 40 or a little above 40. So, the cancers that we see in Africa are a little bit different, but we are seeing the same spectrum as seen here. So, if we're going to attack this problem, if we're going to deal with this issue and be up to date, we have to understand the limitations of what the problems that we have, the challenges that we have. And you've had some of these challenges already: inadequate manpower, inadequate resources, inadequate infrastructure. I remember 5 years ago, or 4 or 5 years ago, and I was telling my friend here what happened. We went to Nigeria, we got audience of the president of the Senate, Speaker of the Deputy Speaker of the House. We got their audience. We thought we had finally succeeded in reaching people who care, who matter. And we suggested the need for training and for education and for establishment of diagnostic centers that are up to the state of the art, which I believe the Nigerian government can afford. Nothing happened. And nothing is happening. I would suggest to you that there's a need for private sector to intervene. And we can complain about the Chinese, we can complain about the Indians. The reason the Indians and Chinese are there is because nobody is doing anything. The Africans don't provide it. Others will provide it. I believe personally that a carefully planned and coordinated investment in the health sector is the way to go. But I must sound a note of warning. Look before you leave. There are many vultures who are waiting for your American money. Sadly, I can tell you, as a friend who worked with one of the biggest oil companies in the world, served for 45 years, got a big paycheck at retirement, went back home, wanted to invest, and a bunch of people looked like they're the right people. Exactly, and they look like they're the right people. And they put together a plan. And he was the sole financier. And he put a large sum of money into the business. A few weeks later, he found the account had changed, names had changed, and he questioned what was going on. And he said, "What money are you talking about? What money?" So, the issue of that, Dr. Critchlow and everybody else have talked about corruption, not just corruption, outright theft happens, and we need to be careful about it. That's a potential risk. It shouldn't be a reason to deter us. It just means that we should be all ears, all skin, all eyes, all nose, all legs, away. Now this brings me to another issue, the issue of technology transfer. I always ask this question, fact or fiction? Is it a fact? Have you ever seen anybody, you come to a village, you are the only businessman in town, and the only one who sells tires, and somebody comes to the village and wants to start selling tires, and he comes to you and says, "Teach me how to sell tires." And the person says, "Sit down, let me teach you how we make our tires and how we sell them." It doesn't happen. Do you think that anybody wants to transfer technology to you? Do you really think so? Do you think the Pakistanis got the nuclear bomb technology by being transferred to them? Do you think the Japanese became what they are? Like somebody said there and said, "We want you to become the greatest car manufacturers in the world"? No! Technology is never transferred. You either steal it or you buy it. How do you think the Iranians are doing it? The Iranians sent their young graduates. They flooded the United States institutions with young graduates doing postgraduate studies over the last 30 years. Those of you who are in engineering, you remember in the 70s and 80s, every graduate student is an Iranian. Everywhere you went, half of the graduate students were from Iran. And the government funded it. And after they finished, they went back. That's how he stole it. In Saudi Arabia or Qatar, what did they do in Qatar? They told Cornell University, "We want you to come and build a medical school here. How much do you want?" And Cornell said, "Pay us so much and we will come and establish it." They got a Cornell dean, Cornell everything, connected with Cornell, they paid Cornell off with some money, they brought money and they built it, and it's a Cornell University in Qatar. Managed like Cornell anywhere in the world. And they bring people who are doing research into it. You don't have to compete for NIH grants anymore. They give you money. What do you want to investigate? Where is money? So that's bought. If you can't buy it like that, then you steal it. I still ask the question, is there room or a place for brains and resources in diaspora? If you are thinking, and I hope you are not, if you are thinking that you show up at the shores of Lagos or Accra or Freetown, and you say, I am the newly delivered Savior from America. You all listen to me. You're wasting your time. Even if you join the faculty of a university, they say, you keep talking all the time. Are you the only one? You're the only one who knows? We don't know her anymore? That's a fact. So if you're going to go, you are not going to treat like the newly arrived king of whatever. It's going to be a fight. Because there are some people who feel very comfortable right now. And your presence will make them uncomfortable. So if you go into the academic system, you're going to face opposition. If you go into business, you're going to face opposition. If you go into government, in government, but the point I'm trying to make is this. What you have to do is to look for the right people. In the midst of all of this, there are the right people who are waiting. Who will say, yes, this is the person we are looking for. We've been waiting. But you've got to look for it. And you don't be discouraged by those who oppose you. Because if you go with the mentality that they're going to welcome you and they don't welcome you, then you come back home and start crying. You are going and they didn't welcome me. I'm going and they didn't. You just ignore those people. Because there are people who are there who are waiting for you. People who are eager. People who are hungry. People who are full of energy. But you've got to look for them. You've got to search them. You've got to be critical of people who are saying yes and no. All you have to do is have your eyes open. That's the key. Keep your eyes open. Look before you leave. If and when you have access to the system, what are the things that must be addressed? What I have here can apply to any part of medicine. We've got to update the knowledge base of people who are practicing medicine, pathology, or whatever in the continent. And it must be done in a way in which it can be sustained. Because if you're going to go establish a laboratory, or a diagnostic laboratory, or a hospital, you're not going to bring everybody from America who will work in the lab, or who will work in the hospital. So you must have a core of locals who are trained, who are educated. You must have people who can practice, and people who are there are not dumb. They just don't have the same opportunity as you have. So all you have to do, first you have to do is identify the people who can be trained. And you've got to train them in a way in which they can keep up their competence, their level of competence. Some of us here, when I came to the US in 1986, I came to a department of pathology at the University of Vermont. I had never been in any Western university, any Western medical establishment. I was fresh as you can get from Nigeria. And within 6 months, my chairman called me, said, Adesina, we're wasting your time, you've been trained. He said, you've been trained, you'll be well trained. Said, we're wasting your time by making you go through the various steps, 1 month rotation here, 1 month there, 1 month there. He said, we have to restructure your program. We have to restructure what you do so that it's beneficial to you, not just making you repeat what you have learned. And that was how my program was restructured. I was put in positions where I was supervising residents, I was giving courses to teach in the university. The first time they will bring a foreigner, see whose accent nobody understands. I remember the first day I went to teach one of the courses. The students were up and down. We don't understand what you are saying. The effect of the presence of a group like this in the health sector must be such that the quality of practice is enhanced. You have to set a standard. And set a standard that everybody wants to emulate. One of the possible effects of setting a standard and getting incorporated in the system is that ultimately there will be room for advocacy, both to private and to government institutions and government policymakers, the various ministries of health. What can you do now before you become a participant on the ground? And maybe a way to actually finding your way to the ground. You've got to get to know the people there. But if you're doing something for them now, when you say you want to come, they say yes. We know you because when you're not going to make money, you came to help us. If when they saw you is when you want to make money, they become suspect of you. It doesn't matter whether you are white or black. If what perception of you is that you are a money maker, people are going to treat you as competition, period. But right now, one of the things that we're doing is that we are putting together faculty. Like for instance, I go every year to West Africa with 5 to 6 faculty from North America and Europe. And we organize conferences for pathologists in the West African region, and sometimes in the East African region. And we have 90 to 100 people, pathologists and trainees, come to those conferences. And we educate them using the same standard. Because one of the things I tell the faculty who come with me is this: when you come with me, when you teach Africans, you teach them the way you teach Americans. No watered down lectures. You say, oh, but they don't have this equipment, I say, I don't care. They don't have it, how do they know that it's important equipment if you don't teach them at the level that it's supposed to be? And so we make sure the lectures are given accurately, correctly, at the appropriate level. The idea is this: those of us who are academicians in this room, and even those of us who are not academicians, one thing we know is that every year you go to conferences, you get CME. That's how you update your knowledge. Dr. Richard was talking about all these .com, and all of these things. Did he know them? Was he taught when he was doing his PhD? This is PhD 20 years ago, when there was no .com. But all he had done was he had kept up with his field. And that's what we all do. We keep up with our field. And many African pathologists, many African physicians are not able to keep up with their field because they can't afford to come to conferences in America or in Europe. Not because they don't want to come, they can't afford it. So for some of them, it will take a whole year's salary to come to America for 2 conferences in a year. So what we need to do is to bring those conferences to them, bring the experts to them. It's cheaper to bring 1 expert to teach 90 than to bring 90 to come to a conference. So if you make such things regional conferences, you educate them, you bring them up to date, it will even begin to change their practice style, and the standard of practice will improve. And that's important, because one of the things I tell people is this. I am here in America, North America, but my family is down there in Nigeria. I don't know who of these people I'm teaching will be looking at the biopsy of my mother tomorrow. And if I don't teach him what is correct, what is the level of standard, he will only diagnose what he knows. And one of the things in medicine is this. This is why you have second opinion in medicine. Your doctor will only diagnose what he knows, or what he has seen before. If he has not seen it before, and he doesn't know it, he will tell you that it's in your mind. Finally, I'm not always right, but I'm never wrong. Thank
you. You helped us with background